Coming to anomaly detection, the detection rates of anomalies when we do a trans-abdominal scan to calculate the gestational age, the overall detection rate is 51% in a meta-analysis, and when transvaginal scan was added, it is increased to 64%. Now there are some anomalies which are always detectable, potentially detectable, and undetectable in first trimester scan. Coming to always detectable anomalies, we can easily detect anencephaly, alobar holoprosencephaly, body stalk anomalies, omphalocele, gastroschisis, and megacystis. Potentially detectable anomalies includes posterior fossa defects, spina bifida, facial cleft, cardiac defects, renal defects, and limb defects. There are some anomalies which are undetectable in a first trimester scan, and that includes microcephaly, agenesis of corpus callosum, ventriculomegaly due to infection or hemorrhage, fetal tumors, fetal ovarian cyst, CCAM. CCM is pulmonary sequestration syndromes, and duodenal obstruction, small bowel obstruction syndromes. So, according to isuog.org guidelines, if we scan the mandatory anatomical structures, means if we scan the head, the stomach, the bladder, the cord insertion, and the extremities. So, these are the structure. If we look carefully on these structures, then we can detect always detectable anomalies in a scan. Now, coming to extendable anatomical structures, that includes the facial profile, preempties or premaxillary triangles, kidneys and spines. We can detect potentially detectable anomalies. And anomalies in first trimester can be detected by comparing the normal CRL picture. So, looking at this image, this is the fetal head, this is stomach, bladder, cord insertion, extremities. Here we are seeing fetal face, here we are seeing the fetal spine, premaxillary triangles, and renal anomalies. So, look and compare these two structures. This is the normal CRL and the normal baby, and when there is no head or malformed head, then this is known as anencephaly. Looking at this structure, this is normal, and this is alobar holoprosencephaly, means single lobe is present. This is cystic structure just beneath the skull of the baby, and this is known as alobar holoprosencephaly. The third one is when the body stalk is not properly formed or malformed body stalk. This is body stalk anomaly. You can see an outpouching out of the abdomen of the baby. This is omphalocele or gastroschisis. And you can see a cystic space which is enlarged in size. This is bladder of the baby and it is enlarged. So this is known as megacystis. Now coming to prediction of maternal fetal complication, we do scan at 11 to 13 week of gestation, as we have already discussed, and that scan is known as anti-NB scan. Coming to this trial, which is known as ASPER trial, it is a prospective multicentric trials which is conducted in two parts. So there are two parts of this trial, part 1 and part 2. Firstly, we will see what is part 1. The ASPER trial, performance of screening for preterm preeclampsia. So this trial is used to screen for the risk of preterm preeclampsia. In this, we perform combined pre-eclampsia screening for all pregnant women at 11 to 13 weeks. Pregnant women with high risk of pre-eclampsia are picked up for part 2 after screening. So, in part 1, we choose a certain group of females who are at higher risk of preterm preeclampsia by doing a combined pre-eclampsia screening at 11 to 13 weeks, 6 days, 13 weeks of pregnancy scan. And those women who are chosen, we pick up those females and use those females for part 2 after screening. So what is included in combined preeclampsia screening? As we have already discussed, maternal demography, certain biophysical markers and certain biochemical markers. So biophysical markers means we calculate these markers in a scan. These includes MAP, PI and PLGF. MAP is mean arterial pressure, PI is uterine artery pulsatility index, and PLGF is placental growth factor. So this PLGF is biochemical marker. So according to NICE guidelines, if we do this combined preeclampsia screening, then the detection rates according to NICE guidelines is 39%, and ACOG is according to ACOG the detection rate is 5%. Multimodal screening based fetal medicine foundation, if you use this FMF guidelines, then the detection rate is 77%. So 39%, 5% and 77%. Coming to part 2, all those females who are at high risk of preterm preeclampsia, from part 1 screening is picked up and are divided into two random groups. One group is offered aspirin 150 milligrams and other group offered placebo. A dose of 150 milligram per day is started because at 81 milligrams, that is very low dose aspirin, the aspirin resistance is 30%, and at 150 milligrams it is just 5%. We start aspirin at 12 weeks of gestation and stop it by 36 weeks of gestation. We start it early, that is at 12 weeks, because placentation unaffected beyond 16 weeks. As we all know, there are two phases of trophoblastic remodeling. The phase 1 is completed by 16 to 18 weeks and phase 2 by 18 to 20 weeks. So we have to start it early. Then we stop it at 36 weeks, not after delivery, because if we do not stop, then there is potential hemorrhage risk in the neonate. We have to take this tablet at bedtime, as thrombotic events peaks at 3 a.m. So bedtime dose will maintain a sufficient amount of hormonal level aspirin level, and it lowers the risk of preeclampsia, fetal growth restriction, preterm birth, and IUD. Now coming to prevention rate of preeclampsia with this aspirin, if we start it at more than 37 weeks, then prevention rate is just 5%. At preterm, that is at less than 37 weeks, if started, then prevention rate is 62%. At less than 34 weeks, if started, the prevention rate is 82%. And if at less than 32 weeks aspirin is started, then the prevention rate is around 90% or 89%. So this trial or the ASPER trials help in screening of patients with high risk of preterm preeclampsia and the prevention through use of aspirin. Now in multifetal pregnancy, evidence-based facts says the best time to determine chorionicity by USG is first trimester, that is at 11 to 14 weeks of gestation. And there are two signs which we can demonstrate easily. First one is lambda sign. You can see a triangular area that is going inside this bag and dividing the bag into two parts. Both fetus are easily visualized, and this is known as lambda sign. This is the peak, and this is the line that is extending between these two sacs. So this is known as lambda sign. And when a single line is seen, single membrane like line is seen, this is T sign. This T sign is seen in MCDA twin, and this lambda sign is seen in DCDA twin. So if lambda sign is present, it is seen in 100% of dichorionic twins at 10 to 14 weeks of gestation or 11 to 14 weeks of gestation. The sensitivity and specificity for determining monochorionicity is 100% and 99.8% respectively. First trimester hence is the best time to label pregnancy when the membrane insertion is close to the cervix. So if sac A is lying just over the cervix, this is sac A, and sac B is lying away from the cervix, this is known as sac B. And through this way we can label sac A and sac B, or fetus 1 or fetus 2, and label according to the position of the baby in relation to the cervix. Now whatever we have discussed is just an overview. Now we are coming to the inverted pyramid of antenatal care. So can you see this pyramid? This is in 1930s, when there are more number of visits in later week of gestation, that is at 37, 38, 39, 40, 41 weekly visit. Then after 28 weeks of gestation, we have twice weekly visits, 30, 32, 34 and 36. Till 28 weeks we have 4 weekly visits, 20, 24, 28, 16 weeks, 12 weeks. So this is normal pyramid, that is not inverted. 1930s. Then comes an inverted pyramid of antenatal care, in which there are more frequent visits in the initial period of the pregnancy, that is at early gestation. We call patient more frequently, and then we decide whether patient is low risk or a high risk. If patient is high risk, then we give specialized care till 37 weeks of gestation. If patient is low risk, then reduced number of visits till 37 weeks, and then we plan for the birth of the baby. So, patient specific risk. At the end of 14 weeks, based on the investigation done in the first trimester, patient can be categorized into high risk and low risk. In low risk patients, we call them at 20 weeks, and if patient is high risk, specialized care is given from 12 weeks to 34 weeks of gestation. We plan for till 37 weeks, and then we at 37 weeks we plan for the delivery of the baby. Coming to inverted pyramid of antenatal care, there is increased frequency of ANC visits in the first trimester leads to risk categorization of the patient. So, initial frequent visits categorize the patient into low risk and high risk, and in later trimester, specialized care is given only to high risk patients. Complication in pregnancy are avoided by assessing the risk in early period of the pregnancy. So, this is not routine; it is still under trial, and the limitation is it depends on good quality first trimester USG scanning center, quality of the lab from which biochemical samples are sent, and this can be overcome by training properly and tie up with the specialized center or a person. So this is inverted pyramid of antenatal care.